Now we're going to drill down a little bit and invite Dr. Margaret Flinter to the podium. Margaret is a family nurse practitioner who serves as the Vice President and Clinical Director for Community Health Center, Inc., which is a statewide federally qualified health center in Connecticut that provides care to over 150,000 patients at a number of primary care settings across the state. In addition to leading practice transformation initiatives across the country, she has really an innovative, an enviable record of creating sustaining approaches to creating training programs for healthcare professionals. You'll hear a little bit more about those in more detail later in a breakout this afternoon. Margaret's a co-director of the Robert Wood Johnson Foundation-sponsored LEAP, or Learning from Effective Ambulatory Practice Programs. And in that capacity, she and a team recently went across the U.S. to look at 30-some-odd exemplary practices and derive lessons about what made them effective primary care practices. So now we're going to hear about one effective primary care practice, and that's the one that Margaret leads.
Great. Perfect. Well, thanks, Jonathan, and good morning, everybody, to the Gates Foundation. Thank you so much for taking time out of your day to come and let me tell you how much deep respect we have for the work that you all do and how much we follow your work around the world. So thank you for the honor of joining you. And to my colleagues who are on the program today, it's a small world, those of us who are trying to transform primary care. We literally all know each other or know of each other's organizations and are really committed to this transformation. I have a measly 20 minutes in which to convey to you the passion, the commitment, the model, and the outcomes of an exemplary community health center. And I'm going to try and do that justice and really paint for you a picture of what a community health center can be, with perseverance, discipline, leadership, community engagement, technology, maybe a little bit of good luck, and definitely some partnerships with both the public sector and the private sector. And I hope that I leave you today with a belief that a community health center that starts today doesn't have to start where we all started back in our ancestral home of those health centers in the 60s, but can build upon the models that we have created. So let me tell you the story of my health center in the beginning, and it's different than the health centers that David talked about that started in the 60s with federal funding. Ours is really the story of a startup. The year is 1972. There's some community activists and organizers, a couple of Wesleyan University students. For those of you who know Wesleyan University in Connecticut, there's nothing but organizers and activists there, it sometimes seems. But also some community residents who just believed that their neighbors and people in their community deserved to be able to have access to care, whether they had the money or not. So in a second-floor walk-up apartment on College Street, a few blocks from Wesleyan, this group of people came together. They took $20, incorporated, that's what it cost in those days to incorporate a new nonprofit, called it the Community Health Center, declared a mission of healthcare as a right, not a privilege, recruited a volunteer physician and a dentist, and they were off and running in that second-floor walk-up until the Department of Public Health showed up, because it turned out they had not realized you actually need a license to operate an outpatient clinic. And the formal medical establishment, which wasn't all that keen on them doing this anyway, had called the health department. And they came and they did their inspection, deemed the hallways 2 inches too narrow, and issued an order to cease and desist. But they didn't desist. Instead, they relocated right down to Main Street. And here's a photograph of Mark Maselli, one of the original founders, and still the incredible CEO of the Community Health Center. So there we were. I showed up just a little bit after this in 1980. I was a brand new family nurse practitioner. I was the first nurse practitioner at the health center. I was the first nurse practitioner in the county. And I was there courtesy of the National Health Service Corps, which had financed my graduate education at Yale. And in return, I was obligated to a period of service for a few years, but I never left. We were really, as I look back, version 1.0 of the patient-centered medical home. Dr. Carl Lecce, still there, 40 years later, was the family doc. I was there, dentist, dental hygienist, a social worker, an outreach worker, a home visitor who went to the homes. And we really just put our shoulder to the wheel and set about this business of delivering really good primary care to people. I look back at that time as we grew slowly in the 1980s, And I think of two big challenges that for me tested whether this model, as David has so eloquently described it, really works. Is it flexible? Can it respond to new health problems? And the two big threats of the 1980s that I thought tested the model and proved it strong, one was the epidemic of homelessness that hit our streets in all of our cities across America when our institutions for the mentally ill suddenly moved to deinstitutionalization. A great idea, but with no plan in the community. And we saw the first epidemic of homelessness on our streets. Huge challenge. And the second, of course, in the 1980s was the AIDS epidemic, which we read about 1 week, it seems, and a week later, we were seeing our first very sick people. It proved to me how important the partnership is between community health centers and between our federal partner. And David made the point about our independence, but there's this partnership. The federal government could create the Ryan White AIDS program and funding. They could create the Healthcare for the Homeless program. They could create the Vaccine for Children's program a decade later. But without an organized delivery system on the ground that was safe, high quality, and reliable, that's just money being poured into a community. It's not action. So very important. And along the way, this is now about 20 years since we started, we actually became a community health center. We had it up until that point. Now, right about 1990, the phone rang one day, and it was the director of Medicaid for the state of Connecticut. And we were still in that 1,000-square-foot retail space. Maybe we'd taken over the bowling alley behind us by then. But we were growing slowly. But the director of Medicaid for the state of Connecticut said, Mark and Margaret, you guys have to help me out here. I'm responsible for the city of Meriden, which was only about 20 miles away. I don't have a single pediatrician who'll see a child on Medicaid. I don't have a single obstetrician who'll see a pregnant woman, and dental care would be in the category of forget about it. Just not going to happen. Nobody to take care of it. I thought, well, that's really interesting. We went to the city of Meriden. We met with the community leaders, both the formal and the informal people. And it was clear there was a need. And we came back to our board. And I think this point is so important. Our board, that consumer-dominated board that David has described to you, was very clear. There were three questions they were going to hold our feet to the fire on before they signed off on this. Did somebody in Meriden want us to be there? They took it as a given. Not everybody would want us to be there, and that's pretty much the story of community organizing. Did somebody want us? Did somebody need us? And can we take on this expansion without risking the rest of the enterprise? We answered yes to all of those, and today the Community Health Center of Meriden takes care of about 15,000 people in that community. And in fact, in each of the zip codes, and I've just one of them highlighted up there, we penetrate into about 70% of the low-income population and can show the clear, objective outcomes of having a strong primary care presence. Decreased asthma admission to the hospital, significantly improved birth outcomes and reduced rates of low birth weight, excellent outcomes for HIV care, and many more. That story was repeated over and over again over the next 20 years, really. Sometimes it was the mayor, sometimes the health director, sometimes just a community citizen calling and asking us if we would come into their community till we arrived at our current state, which I'll describe in just a moment. But we also realized along the way that even building community health centers, brick and mortar community health centers for comprehensive care, did not get us close enough to our patients. For special populations, among the special population, for the HIV community, for the community with addiction, for our LGBT population, for our school-age children, high-risk maternal infant groups, we needed to have even more services. And so we think of these as our key populations, people who need community health workers and case managers and housing specialists in order to make a difference with their health care needs. This also gave rise to the beginning of the school-based health centers. We call this wherever you are, going wherever the patients are. And today, across Connecticut, we have 55 comprehensive school-based health centers, and a child in that city of Meriden or the nearby city of New Britain will go from kindergarten to their senior year in high school, never having known what it means to have a barrier, a delay, or access in getting mental health, primary medical care, or oral health services. And the same is true of the Healthcare for the Homeless program, because we've not ended homelessness yet. But while people are in shelter across Connecticut, they have access to that same model of healthcare. So here we are today. We're a statewide federally qualified health center, and we're not the only community health center across the country that has a wide geographic reach, though many have stayed as a single, what we call more of the mom and pop health center, just in a single neighborhood. We take care of about 100,000 people. We have almost 1,000 staff, a incredibly diverse, motivated, talented, and young staff. The average age is about 35. Many of whom have grown up in our communities. Many of them grew up in the health center and were patients in the community health center. But we started to ask along the way, and Darren, you joined us 15 years ago at this point? Something like that in 2000, and Darren was one of the people that joined me in asking this question. We're building all this access, but access to what? How do we really know that the care is effective? How do we really know we're making a difference? How do we help other people transform primary care? And how do we make this sustainable into the future? I'm going to talk a little bit about the model of care, the research and development approach to healthcare that we take, and then also training the next generation. For the model of care, we're going to talk about clinical excellence in team-based care. For research and development, Darren Anderson has a session this afternoon and will tell you more, but let me just say about that. I started what was then the Weitzman Center in 2005 because it was clear to me that we needed a place to kick the tires on new innovations, to test stuff out, to throw ideas against the wall and see if they stick. Darren came along and has really turned it into a premier research institution within the United States that also provides the kind of performance improvement and quality improvement science to the health center that I think helps make us great today. Every patient has a team. And Donna, you talked about the relationship with people. Wouldn't you want to be taken care of by this team? High vitality, incredibly well-trained, driven to be doing the work they're doing, medicine, dentistry, behavioral health, nursing, nutrition, and wrapped around them some specialists that we need in such high volume that they're directly there on the team, chiropractors, psychiatrists, and the like. But I'm going to tell the story of patients having a team through the eyes of one patient. So meet Ivy. Why Ivy? Because I ran into Ivy the other day, who's now almost 40 years old, and she had her 4 very tall teenage children with her. And I was talking to the kids, and I promised them, because I knew I had this file photo in the archives, that I would send them a picture of their mother as a very little girl when I was her primary care provider back in that 1,000 square feet of retail space. Because Ivy's still a patient of the health center, and so is her family, so is her little sister and her mom, who you can see at the edge of the photograph. So in many ways, the transformation of primary care at the health center, that story is really Ivy's story, and I will tell you how care is for Ivy today. No matter how she hits the health center, by the patient portal, by telephone, or coming in person, there's a team of people that are activated and that know she's here, know what she needs from a prevention and health promotion view, even if she isn't sure. When she arrives at the health center, she'll sign in via a kiosk, and that kiosk will prompt her to get that flu shot today, if it's time for a flu shot, or to sign up for the patient portal if she hasn't done that yet. If by chance she truly is here for something that is in the category of the simple, the easy, and the quick, which we don't actually seem to see all that often, but she might actually see our quick care provider, which we have devised as a way to make sure that nobody goes to the emergency room because we couldn't get them in exactly when they wanted to be seen. But most of her care, as Donna, I think, pointed out, in very similar fashion, so this is all great ideas are beginning to converge, most of her care will take place with the team. And that team, much like Donna showed you, works together as a social unit and a work unit and a pod. That team includes a primary care provider, and Ivy still has a primary care provider, just like she had me a million years ago. That primary care provider has a medical assistant who works specifically with that panel of patients, and that little teamlet, if you will, shares a registered nurse and a behavioral health therapist with another primary care team. And they are ready for Ivy when she comes for that appointment. The medical assistant will do automatically that which should be automatic. She doesn't need to wait for an order or a direction from the primary care provider. She'll order the mammogram, she'll schedule the preventive test, she'll do the measure of chronic illness if Ivy is a diabetic or has some other chronic condition. She'll also coach her. She'll do some of her self-management goal setting, and make sure that the primary care provider, Carl Lecce, can focus on that which only he can focus on today. And if Carl, even after 40 years of practice, is stumped, needs consultation from a specialist, he'll make an e-consult to get that answer instead of having her to send her off to the specialist as we did years ago. If Ivy turns out to be struggling with depression or a chronic health problem today, Carl can instant message the behavioral health therapist, and that behavioral health therapist can come right in, take that warm handoff, and schedule her for follow-up care. And the registered nurse on the team, in the same way, has moved on in her practice. No longer chained to triage and paperwork, the RN is there to conduct her own visits, have her own relationship, and in particular, manage the complex care coordination. And all of them are operating with something that I never had, and Donna, I don't think you did either years ago. They're operating with data. Data about the patient, data about the panel, data that tells us what we need to do today so that all of Ivy's needs can be addressed. And if we're dealing with very challenging conditions, chronic pain, opioid addiction, adolescents with behavioral health, this afternoon you'll hear about Project ECHO from Dr. Aurora and from Darren, which allows all those people on the team to come together in an intensive clinical training and case-based sharing educational forum in order to advance their own mastery of that care. And the RNs even have one devoted just to them for helping with complex care management. How do we know the care is working and how do we know it's good? How do you know if our care is working and it's good? You can go to HRSA.gov, find a health center data, and you can see how we are doing. Now, we had to get over, I'm not so happy with my pap smear screening rate, or maybe we're not achieving the level of control of diabetes or asthma we'd like to. But the important thing is it's transparent, it's honest. This is hard work. It is not easy getting 8,000 diabetics to an A1C under 9 or clearing the viral load of our HIV patients. But we invite you to go and take a look, see how we're doing, see how the country is doing, and continue to put our effort where it needs to be. I think I only have probably 2 or more minutes, but I want to talk about training the next generation. Across the country, health centers have always been engaged in training the next generation, but we're taking this to a new level. There are teaching health centers that provide physician residency training. We've taken a different tact. We asked the question when people kept talking about the shortage of primary care providers, well, who does want to be a primary care provider, and how can we support them? And one answer was nurse practitioners, if we can give them an additional year of residency, something that hasn't been part of that model, to be trained specifically to the role of primary care providers in the safety net setting. We've developed the model, but today there are 40 across the country. Their collective success is evidenced by the fact that 92% of them on follow-up are still practicing as primary care providers, 87% in community health centers. But we didn't stop there. We went on to develop a clinical psychology residency program because training psychologists in an integrated primary care model to warm handoffs makes the most sense. And this year we added the National Institute for Medical Assistant Advancement, and we will talk about that a little more this afternoon. Medical assistants are vital, and they are not well served by the current for-profit proprietary training system, and we're going to turn that system on its head. And Darren is leading up an administrative leadership fellowship to help people lead health centers as well. So a couple of key points. I want to emphasize the point that David made, that health centers are economic engines, and we have a responsibility to be in this business of addressing income inequality and a livable wage. And so our minimum wage at the health center now is $19 an hour for the most entry-level position, which is about almost 3 times the national average, but very important, and tuition reimbursement that helps staff move forward and advance their futures. 2, community health centers are centers of health in their community. They need to be places that people are comfortable being, and they need to serve a purpose beyond just the delivery of clinical care. And across the country, through the Affordable Care Act and the Reinvestment and Recovery Act, health centers have been rebuilt. The third, the Affordable Care Act reduced but did not eliminate the number of uninsured people in this country today. It's still about 14% even in our health center, which had Medicaid expansion. And so the need for partnership with the federal government, with other payers, remains very strong. But that is an absolute, that care is on a sliding fee, and it reduces to 0 for people who live in poverty. And last, we're a socially responsible business, just like all socially responsible businesses. We have an obligation to our people and to our programs. We have an obligation, though, to be successful as a business, to have a margin at the end of the day that we can reinvest, whether it's in new services or new facilities or in the kind of research opportunities that we need to undertake. I would be remiss if I left you with the impression that we worry about nothing and we've achieved nirvana in the community health center world. That would be great, but it's not. There's plenty to keep us up awake at night. It is very hard, demanding work, and we think all the time about how to retain our primary care providers and, in fact, the whole team. We are still paid for volume, not for value. We hear it shifting. We will make any system work, but we need that value-based system to help us. But we're always going to have volume. We're always going to need to respond to a large number of people who need our care. So that keeps us up awake at night. The second, and just something that makes us cringe in the community health center world, is we know we should be doing a third of our care virtually. And I'm really looking forward to hearing from Wellesley this afternoon. Not all of our patients would do well with virtual care, but a lot of situations would. But the payment system doesn't allow for that at all. The public payers are the last to go there. We look forward to that. We are not doing as well as we should with engaging our patients in wearables and managing their own data and communicating with us that way. We've done some early forays with studies into that, but we need to do more work into that. But at the end of the day, the community health center system is an incredible system. I think it offers promise across the world. It certainly delivers on the promise of healthcare as a right and not a privilege in the United States. And I and our board of directors really thank you for the opportunity to share the story with you. Thank you.